Thanks to the NIH, we were able to make a case for, and were successfully granted a supplement to this June, bring 3 colleagues from Liberia to spend the month with us at the Berman Institute of Bioethics. And as often happens with these things, it seems like this relationship with these 3 colleagues is the beginning and not the end. So we're very grateful that they're here. The plan for today is I'm going to introduce our 3 guests. 2 of them are going to speak each for about 15 or 20 minutes, and then we'll just open it up to Q&A. So with apologies for using my cheat sheet piece of paper here, I want to make sure that I give you some of the key details. So our first speaker is going to be Nelson Dunbar. Nelson is the Director of Research for the Minister of Health and Social Welfare in Liberia. Mr. Dunbar received his public health and epi training by getting an MPH through a joint program at the University at Huntington University in Liberia and the Royal Tropical Institute in the Netherlands. And through his role as being Director of Research at the Ministry of Health in Liberia, he has also supervised the Liberia Daily Situation Analysis Report on Ebola for the Ministry of Health. Our second speaker is going to be Jemee Tegli. Jemee is essentially presenting on behalf of himself and Edward Smith, who will be the third person I introduce, but Jemee will be the speaker. Jemee is the Center Director and Coordinator of the University of Liberia Institutional Review Board. So for those of us in the ethics world or even the research world, that is the main IRB that's had oversight for a lot of the research projects that many of us have been hearing about. He joined the University of Liberia Pacific Institute for Research and Evaluation Africa Center in May 2007. He serves concurrently as the Center Director and Coordinator of the University of Liberia IRB. He also, relevant to this presentation, works with the U.S.-Liberia Clinical Partnership Program, which is, for those of you familiar, the PREVAIL study, the Partnership for Research on Ebola virus in Liberia, as an IRB and ethics consultant. And he has other background that I won't use up his time in letting you know about, but he's worked on other collaborations with the NIH as well. Edward Smith is our third guest from Liberia this month. He is an associate professor of agriculture at the University of Liberia. He obtained his MPhil degree in agronomy and animal science from the University of the West Indies in Trinidad, and his bachelor's in agriculture from the University of Liberia. He's participated in bioethics trainings through PIRE, where Jemee works, through AMNET and the WHO, and he worked on the Central Agricultural Research Institute with a lot of other agricultural background. He's also been a member of the University of Liberia Institutional Review Board since 2005. So we can all welcome our guests, and then we will start with questions. So thank you for being here.
Good afternoon, everyone. As they have said already, I'm Nelson, and it's very good to be here and to share with you as well our experiences when it comes to the Ebola response in Liberia. But I will first of all start by telling the Berman Institute thank you for allowing us to be here, and also telling you thank you for allowing your loved ones as well, who also travel far distance to Liberia and help us to control the disease. And because it was a global approach, there's a reason why Liberia was able to gain some effort and resourceful end for now. So, like it is, I'm going to be telling you particularly about the overview of the Ebola response in Liberia. And in that, I'm going to give you some highlights on particularly what are some issues that came out and what were some of the best practices exhibited that enable us to be declared Ebola-free today. And as well, I'm going to explain to you on particularly what is the next step forward. What is Liberia thinking at the moment? Okay, so first look at the background of Liberia. You all know that Liberia is a low-income country, and with respect to the maternal mortality rate is very high in Liberia, And unfound mortality rate, surprisingly, is one of the indicators that have really improved in Liberia, because as you see the trend from up all the way down after 2010, it means that we have now had less than 100 per 1,000 live birth when it comes to unfound mortality, which is a great achievement for Liberia. So as part of the overview, while many people have learned about the response in Liberia, some people also think about how really was it, what was the structure. So I thought it wise to show you exactly what was it. So the response as it is, as you see, it had different levels. And meaning this is a part that we said that really didn't work, and we had the support arm and we had the operation arms. So all here were the very thematic area, but specifically we had a laboratory area, epi-surveillance, which particularly at work, and then we have social mobilization, contact tracing, case management that is also mixed with the psychosocial component of it. So to get to our main topic, as you have read or heard, Ebola started in Guinea, but we did not know as a country, particularly Liberia, that Ebola existed in Guinea until March, when it was announced by the Guinean government. Surprisingly for us, while it was already announced, this disease had already entered into Liberia. And so as you see there where you have Lofa, Lofa was the first place we detected our first 2 confirmed cases in March. Now, a country like Liberia that have a particular traditional setting and way of doing things, there were a lot of statements, a lot of things being done or being heard, particularly when it comes to Ebola. So after it entered Guinea, we also tried to see what were the issues that really came up at the beginning of the response. So at this time, there were a lot of denial. There was no one in Liberia who thought that Ebola really existed in Liberia, because while it is true that there are scientists around, there are researchers around, there have been no historical trend of Ebola linking to that of West Africa, particularly in the region where it was. So people did not believe that. And we had, particularly the healthcare workers, did not have any knowledge when it comes to Ebola. My first training or work that I did when it comes to viral hemorrhagic fever was in 2010 in Sierra Leone, where we decided to open a viral hemorrhagic fever center that will focus on mainly Lassa fever and Dalo yellow fever. No one had any time about Ebola. So it was quite strange. And then what makes it worse is that, having a system that have been ruined by a long war, a lot of conflict, people did not have much interest or trust in a particular system that we have. So when the Ministry of Health began to announce this, it wouldn't appear to people like this is a means the ministry want to move out money to use for another thing. Okay? So everyone did not really have in mind that we had Ebola. So you have traditional burial practices still going on, but key to that was a poor community engagement, local conspiracy theories, and some of those theories were Ebola is just another genetic modified model that has been designed from that of HIV to use as a means to get rid of certain group of people. And this understanding was quite extensive because it wasn't only in Liberia, and that's one of the problems really we have when it comes to community engagement. What are you going to tell people who think that you, who is a healthcare worker, is also involved in the process of spreading the disease? While all of those struggles were going on, by late May, because the disease started in March, few cases, and then the whole of April, there were no much case or there were no case at all. Surprisingly, May, the last week of May, cases began to pop up almost in the very key counties like Nima, Lofa, you have Margibi, and you have Montserrat that hosts the capital city of Monrovia. There people began to know now that the disease is really in Liberia for true. But this was only known among people of certain caliber. It's not because people were not educated, but education as a whole, if I saw that do not have direct a positive change when it comes to behavioral change issues or the way people think. So there was some educated group who also felt that the ministry, the government is still carrying on false alarm because you want to generate money from around the world. And while we still have all of those problems, the third wave of Ebola came. And as you can see the map already, it tells you that Ebola have engulfed already the entire Liberia and also extending greatly in Guinea and that of Sierra Leone. At this point now, like I tell you, I was in the Netherlands. I have completed my study already. And then, you know, information spreads a lot. So whenever we visit places, like we go to entertain ourselves and I introduce myself, and they'll say, oh, which country is Liberia? So, oh, Liberia, yes, the Ebola country, yes. You know, and I become very stigmatized wherever we go, and sometimes you even refuse to tell people, someone whether you are a Liberian. Because everybody knew around the world exactly where was Liberia, and the high increase in the death toll when it comes to the Ebola response makes Liberia to be known too much with respect to the Ebola. Okay? So, why it was that way, there were a lot of effects that occurred particularly from the Ebola after spreading across the entire Liberia. And some of those were, like we listed here, the educational system was completely closed down. Now, institutions that had a lot of workforce, like the Ministry of Health, the Ministry of Education, Agriculture, the government announced that non-essential staff should be laid out to stay home and rest. Most importantly, like the women to stay home so that we can avoid the too much of contacts and further spread of the disease. So it reminds me, many of you are professors, many of you are very hard-working groups. So if you're in Liberia, wouldn't you go and put your name down as non-essential staff? Even though some of the directors, like I know directors for that matter, wrote that name down as non-essential staff. Because you don't want to be somewhere that is exposed. You don't want to have any contact with the hospital. You don't want to move into the field because everyone was afraid. And who knows, maybe if I was in that block, I would even reading my name as well as non-essential staff, despite what I was involved in. So we also look at the borders were all closed and traveling around for Liberia was difficult. Flight stops, very few flights, and that's why I still say thank you to the United States government. It's not because I'm here, but it was the only country that was really open to Liberians, despite the situation. So at least we have somewhere to find means or to seek refuge. So that can be remembered for good in history that yes, while our neighboring the Ivory Coast border was closed, other borders were closed, there were countries far away that still accepted us to travel. So the government, key policy recommendations were made during this time, and one of those was that the government orders that all causes of Ebola be cremated. Can you imagine? There's a disease that, because Ebola was already everywhere, someone dies, they might not have even died from Ebola. But you are there and this family member is taken in a very strange manner and taken to a place where you will never know where he or she is. Okay? And then another one was, we announced that all deaths being considered as a suspected deaths. So it doesn't matter whether it was a vehicle accident, and having vehicle accident death, it doesn't mean that you do not have Ebola. So one of the strategies that was being used in Liberia as compared to the other countries was to make sure that anyone who dies, you are considered as a suspected case until the test show that you are negative. And I see that as one of the success stories behind the control of the disease. So, like I said, I went by Liberia. This is how, as you see the graph, telling you exactly the path Ebola was taking. And we who are statisticians, seeing this tells you, if you are going to project, I don't know, you might be projecting at the end of between January to February, because as it goes high, to come back down, you know when it's going to end. And when I came, like I said, I was really responsible for this component of the surveillance system, and I worked with my immediate boss, Dunbar, who some of you might have heard of already. So this was the system that I used, and this component here is a lab, the community care center, the dead body management unit, the ETUs itself. And this is the Excel document I will receive from all of these on a daily basis. It comes here from the county level and it comes to where I sit. And we verify all of those data, call from around. If it is a suspected case, we send in teams to do visitation. If it is a confirmed case, we also send in teams. So this key component was the one that was really the sources as well. The case investigation and contact tracing. It's really important to know that Ebola is a very dangerous disease and very, very difficult to control. Someone has died from Ebola already and is confirmed as an Ebola death. How can we know how many contacts did the dead body have? It becomes very difficult. You are tracing sometimes things that you cannot see. So it was very important at the time for the case investigation and the contact tracing group to really find out where did this person visit, who came in contact, where did he go, where did he sit, which taxi did he ride, or how many people were in the taxi. It's a very complicated thing to do when you are sitting on a daily basis. Okay? So those are some of just the summary of some of the roles that were carried out. We received suspected and probable cases from the county level through email, phones, and rumors. And in here particularly, I would like to focus on the rumors aspect. Ebola is not like ordinary disease that people would think that whenever you hear about rumor, you feel very relaxed. The rumor is the most difficult one to investigate, but at the same time, very important. Okay? So we were very, very serious when it comes to someone saying, oh, I heard that there's a disease in Nima. If I heard that, I call the county health team immediately, call the case investigators here there immediately for someone to move in and find out whether it is true or false. If it is lied, yes, then it's better for me than to say, oh, it's a rumor, let's just forget it. So it was something key to look at. So all of these groups were the ones that were informing every day whenever those information came. Then here also we received from the lab the treatment unit and now the community results. So some of what we did, the dead bodies are from the community. We reported how many deaths occurred in the community. We also tell how many were confirmed, how many were on the contact list. If anyone has ever had experience with these kind of diseases, those that are on your contact list tells you your success story. If confirmed cases occur and they are all on contact list, you are making progress. But if you are following on now on the Sierra Leone and Guinea situation now, there are confirmed deaths that are occurring that are not even on contact list, but they are even, the worst case scenario is they are among dead bodies. It's that you keep going back from step 2 to step 1 because there are still deaths in the community that are confirmed, and you don't have those on a contact list. So what were some of the challenges that really occur or we experience when it comes to the Ebola response? And one of the key ones here is this poor coordination. With the logic that people living from around the world to go Liberia to help, everybody had their own personal motives. Institutions had their own motives. And then people say, oh, Liberia might not have really the educated group of people to do the type of work that is required. And so, and as part of my ethics lecture here, I really remember when we spoke about capacity, when someone said institutional capacity is better than an individual. Okay? This group that came, they had their own work to do. While we are working, many are publishing papers. And if you look at some of the published papers online, some people publish, they just put in Nelson, Dunbar, Luke Bow, and other groups and publish, even without you knowing. Because as part of growth as well, when it comes to the scientific setting, publication is one of the key achievements, and everyone wants to do it, despite the situation that occurred. So coordination was very key for us, and in us as a whole, we already had our own problem. The main issue about this coordination here was the high turnover of international staff. CDC did a lot of good job. WHO did a lot of good job. Medecins Sans Frontières did a lot of good job. But CDC staff doesn't stay in country for more than 3 weeks. And that really carried us backward many of the days. Because someone came last week, I explained everything we are doing. We began to work. After 3 weeks, he's gone. Another person come who have to start from the beginning to explain whatever happened after 3 weeks, he gone. And so it was really a problem for us. So that's one of our recommendations when I visited Washington in March when we had this this innovative and technological program there. I explained clearly that whenever there's a featured incident, CDC should have a permanent office. That is important. Then we realize capacity. Not individuals coming in and flying every now and then. So the traditional practices were still there, poor community engagement was still issues as it occurs. Now, this is one of my beautiful graphs that I like. And the reason it's beautiful for me is because you remember the graph I showed when I told you when I came what was growing up? Okay? Yeah. Now you see what is happening here is no longer growing up now, it has come down. So we did this projection along with one Professor Hans Rosling. He worked with us in Liberia for over 2 months, and this was our projection. When we did this projection, it was in November, between November to December when we did this projection. And at that time, this graph ends right here. And we said, over time, by December, January, February, we will have begun to report at least half a case or one a case in a day. And over 2 to 3 days, we'll begin to report like 1 case. And if that works, then we hope that this disease can be controlled between January to February. If it doesn't work, it will still go anywhere further. And luckily for us, every day we present, you see this graph coming down. And you know that figure, as you plug it in, it just reads by itself. Until we reach here, as you see the diagram, that tells you how worried it was. We were in February, almost like completing over 32 days without confirmed case. Happy that yes, Liberia is finally getting to the end. And I had this U.S. colleagues that were working with us, the U.S. Army, they were working with us in the office, and some were leaving on that Friday, March 20th. So we tried to at least have a little celebration. And I heard my phone vibrating in my pocket over and over. When I took it up, we have 1 new case. It was so strange. So it means that we're starting, we began to count from the beginning all over. Yeah? But luckily for us, this is where it all ends in Liberia in March, as you see it. So our success stories look at the strong political leadership. While it is true that there were many doubts about the political system, the government was also willing to accept international communities. She was willing to work with people internally to make sure that this disease was controlled. So we have effective panel coordination as well. We have the global financial and technical support, which is very, very key. While it is true that money or technology was not the main resources needed to control the disease, because if you stay away from me by contact, this disease over 21 days should be wiped off. So it did not require me having a space suit or whatever suit to do that. But on the other hand, money was also important just for the extreme case, since it is very difficult in a situation like Liberia where tradition shows that you have to shake your colleague hand every morning, you have to hug, you have to do that. It was important to help us move forward. So also, having information available, data speaks. And based on this data, we're able to get projections, we're able to determine where resources were needed, we're able to determine our human resource gap, we're able to tell what is required. So it was so important to help. Importantly, and all about it is the community willingness to change. I said it in Washington, I look at all other technologies. The US government has done a lot of great job. People, there have been a lot of good discoveries. But there's one question to all of these discoveries. If you have, for example, a rapid diagnostic test that is very good, when do you utilize that? Only when you collect samples. If there's no samples, it doesn't read. So if the patients do not go to the facility or to that point to collect samples, you cannot analyze anything. So logically, it was very important for the response to take another trend, to engage community face-to-face, interpersonal-wise, through communications, community-based organization, establishment committees, to make sure that they are willing to change. And because they were willing, That's the reason we are where we are today. And an example you can see for other countries that also have the disease. If people are still keeping the sick ones, people are still doing unsafe burials, then you should know that community has to be engaged fully for change. And that's the only way you can cover Ebola completely. So what were the lessons learned? We knew that from all that happens, while it is true that there were surveillance systems there, we need a very proactive surveillance system to rapidly detect. Study has shown that countries that have suffered from Ebola over time still experience occurrence of Ebola. So by the time we are free now, our main concern is we should have the capacity and the system in place to detect and to respond and make sure that it doesn't go the level we experience. Okay? And also, we want to look at strong community engagement and participation. We want to look at enhancing communication system that is direct, clear, and well understood. So the next step forward, we want sustainable and quality surveillance system. We want to look at increase in surveillance and field epidemiology. This is key because it helps you to know, to analyze the disease by the trend, where, who, how, and all of those, they are very key, and these are the kind of capacity that we need now. And we'll also look at the development of the public health laboratory. It's important, and these are things we are looking at. So, the last of that I'm going to talk about here has to do with the undertaking of the Ebola-related research that we need to do. I'm going to remind you that there are articles that told us that a survivor has a window period of 90 days to be clear of the virus from the cell, right? Or from the system. But you remember our story just from the American doctor that got infected in Liberia? There was a test done on his eyes. And it still tells you that the virus still survived in the eyes, right? It's still there. Now we're standing also in Liberia. The last case in March, there was some investigation done, and there was this rumor, not yet proven, that this lady was confirmed Ebola, and she was exposed from a man who survived from Ebola and was discharged from October 2014. So if you check the time, it's over 4 years, 4 months. So that tells you that studies need to be done to make follow-up on those survivors, look at all of the health issues that they experience, see what is the viral load over time, so that we have better information. Because there's no much good literature on Ebola. That was very troubling for us because we told the people, the community, the public, that stay on any sexual intercourse for 3 months or 90 days. And if that is not true, we need to do more when it comes to research on Ebola. Okay? And also to follow up on the survivors. So to conclude on this, I want to tell you the reason why it is important for Liberia to keep continuing with the 90-day surveillance and onward. Now, this is the current situation in our neighboring countries. This is Guinea still, this is Sierra Leone, and this is Liberia. What is good is that around the border points, there are no cases now occurring there, but yet and still, it tells you that Liberia needs to be consistent. We need to be more proactive. We still need your support to continue with these interventions until the countries are all cleared. Okay? That's the reason we still need to move forward. So lastly, this is just a summary here telling you the entire trend, what happens, and so the slides can be available for that. And then for summary, this is what happened. We reported our first case from March 20th, 2014, and the same March 20th, 2015, the last case was also recorded. So these are the number of confirmed cases, suspected deaths, and so forth. And the cumulative death. So this cumulative death, we have more death because of the policy that says record all deaths as suspected deaths. So some of these were also added onto that. So with this, we are still doing reclassification so that we have a more clear final data that can be presented anywhere for people to make use of that. So this is a photo. This is Professor Hayes Rosling. This is the U.S. military guys. That these guys sat with me in the office all through the day until 5, 6 before they go back to the base. And then anytime in the night when I even send a text to any one of the guys, they are willing to produce any report. They are the most generous of the groups that I see that work for the entire response. And that's why everywhere I present, I will show these photos to let people know that the military is a diverse field. It's not only about guns, but people can also do other good jobs. And I really appreciate them for that. I also appreciate Professor Hayes Wilson a lot and the rest of the team that help us. So I want to say thank you again for the opportunity, and we are glad to share our experiences, and there will be time for questions. You can ask whatever question you like. I'll be willing to respond. Thank you.
So I think let's have Jemee do his presentation, and then we'll open it up to questions for all of our Liberian guests.
Yeah. All right. Hello. Hello to all. Hi. All right. I will be looking at the ethical perspective in terms of the Ebola response in Liberia. All right, so so we all know that I guess we all in here have done a lot of reading on Ebola. So you know it is or it still is the worst, largest and more complex case right now in West Africa, which has become a constraint to all of us globally. And so you will see that when we first heard about Ebola in Liberia in March actually last year, we had other research taking place in country not related to Ebola. And so in some of these meetings, we raised the issue that we've heard that there is a strange disease in Liberia called Ebola, all right, that came from somewhere in Central Africa. We know that there will be a lot of people coming in to want to find answers, and this is going to involve complex clinical trials. And we also knew that the CDC, by July, we start hearing about CDC trying to get some information about what happened in Liberia. So you have few people going into Liberia trying to get some information about Ebola. Because as Nelson said, so March, there's 1 or 2 cases. April, there's 0 case. May, there's several cases, now sporadic across the country. And so by July, it became a national emergency. And so there was sporadic death across Monrovia. And from an ethical standpoint, we did not have the kind of preparedness, even if there was to be a forthcoming research. From an ethical standpoint, we did not have that kind of diverse expertise to go into, reviewing Ebola-related trials. And so in August, the government of Liberia announced a state of emergency. The country was locked down. Everywhere closed, border closed. And so you had doctors, physicians that were coming down with the virus. And so the name Zima propped up. And so the Minister of Health or the Secretary of Health in Liberia, Dr. Gonigali, engaged some friends here in the U.S. and someone told them, the health authorities, about a drug called Zimab that the military had that could possibly be used to prevent Ebola. And so this drug was brought in. And it was given to doctors because at the time everywhere was like crazy. No one knew what was happening. And so when the drug came, they took it straight from the airport, straight to where the physicians were, and they started to immediately test it. And it was done on compassionate grounds. There was a big debate in Geneva about why should, why should a Zima be given? How safe is the drug? There were a lot of questions raised. But because of the state of emergency, of public health emergency, the WHO acquiesced that it should be given. And so at that time, there was a series of communications between some people that were really interested in the protection issues when it comes to giving Zima. And so the National Health and Science Research Ethics Board, as the government arm, and us had some, at the time you can't visit your friends, so everything was like by phone. Do you know what's going on about the Zima? He said, no, but we heard that the government have agreed that they should give it to the physicians because they're dying. But is it ethical? So those are issues that we're debating. And so from the university, we wrote a letter to the Secretary of Health, explaining to him in a detailed letter about this drug, in terms of, we want to know the profile of the drug, the protocol involved, what was something like, was he dying and just saying yes, these kind of questions. But looking at the heat of the moment, the minister could not readily answer us. Okay, he said, look, not in a reply, but he said orally, said, look, people are dying. Then you're speaking of ethical issue. Right now, we're not talking about ethics. People are dying. We're trying to see whether this can work or not. As far as we are concerned, the WHO is aware of what we're doing. So the issue of ethics will get there. But right now, people are dying. And so, we will have to do what we can do, but we know that we're concerned about the life of Liberians. But this is a drug that is being tested. It's not going for trial. It's just a clinical care service that we are delivering. And so, thereabout, we also found out that the drug did not do well because those that took it, they died. Those physicians died. And the death toll continued to loom. And Liberians continue to live in a state of fear where like 150 deaths every day. That's what you hear on the radio. You hear syrup through the streets every day. And so people were just home, no visitation, no touching, no handshaking. So fear was just all over the place. And so as Nelson said, so you will see that by this time, by May 9th, these are the total deaths that actually occurred in Liberia and the total infections from the data from the Ministry of Health. Now, during this period, the government of Liberia again contacted the National Institute of Health, or the DHSS, to help find some solution to the Ebola situation. And so what happened was that in August or there about September, there was a team that left from here, from the NIH. They had a local library scientists on the ground, and they were able to set up, use some of the librarians that were on the ground to pool resources together to try to answer some of the questions surrounding Ebola in terms of conducting some clinical trials. And so professionals from all backgrounds, from the university, from the medical school, clinicians, community mobilizers, so they met during a period of September, the whole of September, there were meetings every day trying to brainstorm and find a way to help conduct clinical trials on a possible cure for Ebola. And so, but there was structural and institutional gaps that needed to be reorganized. Because for the U.S. standpoint, before they conduct trial anywhere, there has to be local commitment. There has to be a lot of regulatory and ethical issues that have to be, that have to be adhered to. And so the government, we have in Liberia, there is an institute called the Liberia Institute of Biomedical Research. They've established in the 70s, and they had an ethics board, but it was not ideally organized for such a complex review. And so they were reorganized about December, and that board is today called the National Research Ethics Board. So with the partnership between the U.S. and the Liberian government, there was an acronym called PREVAIL. That's the Partnership for Research in Ebola Disease. So this is a structure that was set up, and they decided, they did a proposal to do a phase 2 trial, a phase 2 clinical trial on a possible 2 vaccines that may prevent or cure Ebola. And so the WHO was also involved in this. There were a lot of email and telephone conversation between the WHO global team and the WHO research global team and the Liberian team, because there were a lot of capacity gap. The WHO came in, conducted some training, for the Liberian local ethical team. And so it was this team that reviewed the protocol that was submitted by the Liberia, the U.S. clinical team. And so I can tell you that these were complex documents, because right now in Liberia we don't have a virologist. Someone that that will look at the protocol and advise you. But there were a lot of options available, where the other ethicists around the world that are friends, all right, that were willing to provide some expert opinion, all right, through signing confidential documents. And so there were resources that were leveraged, and the Liberian National Research Ethics Board were able to go through, it took 2 to 3 weeks to cut those complex protocol into pieces. And a lot of the issues that came up, as you can see listed, were these: the informed consent process, the SOP for the sites, provision of, for example, this. There was a phase 1 that was done here in the US, in Europe, and some places in Africa. So those documents were needed to inform the review of the phase 2 protocol. The issue of SAE, because nobody knows what's going to happen if someone is injected with one of those vaccines. The issue of patent royalty for Liberia. These are very, very critical debates or discussion amongst about 21 persons, panel that were reviewing this protocol. Alright, the issue of full disclosure of patent right, the issues of compensation, which is another very critical issue. The issue of, for example, PREVAIL taking away an already diminished health system, taking away all of the good physicians or all of the nurses to work with you when people are dying. So these were highly ethical issues that they grappled with for several weeks. But it was finally approved after a series of back and forth. So right now there are a series of studies that have been approved that are ongoing, like the vaccine trial we just talked about. There's a confidence plasma trial that's ongoing. The Dunbar trial is ongoing. The natural history study on survival that Nelson just talked about is one that was just opened yesterday in Liberia. It started yesterday. And then there are a lot of anthropological studies that are also ongoing. And there are others that, there are other scientists or researchers across the world that are interested in doing other research on Ebola. Okay, this is just a picture. This is such a picture that I guess those that usually watch, for example, CNN, which is globally watched, or the BBC, you will see that this community is called West Point. This was one of the communities that was quarantined at about July, August. In this community, the issue of community engagement, one of the setbacks that they had, a lot of fear, among misinformation, community apprehensions about seeing health workers coming in with ambulances, and like you're bringing the virus into the community, schools being used as makeshift clinics, and so this community rejected. They didn't want to see any health worker in it's a slum community, and so there was a shootout here between the security forces and a riot. I would call it a riot between the security forces and the citizens, and this was all on the international wire. And so the issue of community engagement is very critical when you wanting to do, intervention in health emergencies. So these were images that you saw almost every day. I mean, during the heyday of the Ebola crisis, see young babies being taken from homes and taken to ambulances, for cremation. So these were scary times. This again tells you about the tradition, some of the traditional practices. These are two. They may be suspected. I mean, they may have died from Ebola. This is a Muslim community. All right, in Africa or in Liberia, the Muslims, when you die or when someone died, they should have washed the body before burying. And so a lot of them died because of what they were doing. So you can see here they're all standing there, and he's giving the last prayer before they are buried. So it took a lot to change their mindset about not touching bodies, not washing bodies for burial. And so there are other fundamental issues that we continue to grapple with. For example, ensuring that investigators engage local communities in terms of building trust, as I'm just saying, ensuring that bridges in communication are breached, ensuring that, because issue perception and beliefs is always a strange phenomenon, whether here in the US or whether anywhere in the world. People always have, their thought processes are different. And so these are issues that communities and investigators grapple with every day. Ensuring false hopes are eliminated. That's another thing. Some researchers go to poor resource country and they raise false hope. So these are things from an ethical standpoint, when they come for review, these are things that we push them to adhere to, or else, they're going to fall into trouble. Or putting politics in the back burner. Other people have different, political interests. All right, and also ensuring that Liberians are always involved in the research process. It also helps to leave capacity behind, and not just you go in as a Westerner and you have your own team and you are not involving the local researchers. So these are critical issues that always come up doing reviews. Okay, some lessons learned from the outbreak was that I didn't really mean to say no. Yeah, okay. And like a lot of people believe that when you go to a resource constrained country, that you don't understand the local context, you fall into trouble. So, and mind you, their capacity in those. If you ask the right question, you will see the right people. So other Westerners go there, they don't understand the local context, and they get mixed up, and like they become frustrated. And so I can tell you that there are a lot of rich local resource base that you can harness when you get on the ground. If you ask the right question, you will get the right people. And government was very slow in acting. Again, perhaps this was the very first time that such a scourge, just abruptly surfaced in Liberia. And so it took the government a long period for it to grapple with the actual reality. Health workers too, they died because they didn't know what was happening. Okay, they had no training in health emergencies. What do you do? How do you protect yourself? So this, I think that it was just zero. And what are the next steps? Again, there's a need for more natural history studies on Ebola. Right now, with the one that was opened yesterday, they will be looking at actually the eye. Okay? But again, as Nelson said, we don't know. Someone that has survived from Ebola 90 days ago, something could be hiding somewhere. All right? It could be in his semen, or it could be somewhere, somewhere in his or her body. So there's a need to conduct more studies on those that evolved, survived Ebola. There's need for continuous training on research ethics in Liberia. There's a need for advanced training opportunities for RB members in bioethics. There's a need to capacitate an effective secretariat, particularly at the national level, that will really streamline protocols, that come for review. And there is also a need right now. The University of Liberia, they are taking this very seriously. The president of the University of Liberia, Dr. Dennis, he's thinking about incorporating bioethics in the curriculum of at the University of Liberia. The government of Liberia, I think right now, as Nelson was saying, there's a great deal of need to do here. All right, in prioritizing research and prioritizing ethics. So I want to say thank you for your attention and thank you for the opportunity.
So, Nelson, why don't you come back to the front? I don't know if Edward wants to talk, or just the two of you? Edward, why don't you come up as well?
In general, changes in custom, like changes in culture, how that process went, if you guys encountered ethical questions throughout that, or sort of what that stands.
So with respect to the burial practices, what we did not try to do was to tell someone you have to change your entire behavior. So what we established was we have a committee that is already in Liberia that work with anyone who has lost their loved ones during that time. We are able to give you all of the support to carry on safe and dignified burial. It wasn't the case like cremating bodies anymore, because we knew very well that people were very hostile to that. But in order to change people's behavior and encourage them on how to perform burials, we needed the health team to be available. We are there with you. You carry on all of your different prayers, but at the same time, it's a trade-off. We tell you, Lord, please, you can do whatever you want to do. It's a loved one that has passed, but do not touch the body. We are not going to allow you to bathe the body. The health team can do that because they are protected to do it. They have the knowledge to do it. So over time, people began to agree, and successfully, the government was able to identify a space for burial. And so burial that was now being done was being done in collaboration with the family member and that of the health team. Yeah. So we guess over time that will change as well, because it doesn't quite make a lot of reason when, over a long period of time when there are no more virus in the land, and tell people that, look, before you bury your body, we have to be present, we have to do this, we have to do that. But for the moment, that's what we have asked of the people in Liberia to help us control the disease. And that has worked pretty well. Yeah.
Just comment. In addition to what he has said, based on the community engagement that went on, a lot of them got educated. So they're very cautious. They learn lessons, and a lot of them are applying it because we know that our neighbors still have the disease. And this is why we are free, but cautiously free. You know, everybody is very cautious, you know, and so barrier to this is you know, giving a body. Part of the culture has changed. You don't see a lot of people shaking hands. Liberians love to shake hands. They love to honk, you know, and all those things. And we just think we should live with that now. So that's it.
Yeah, please.
Hi. Hi, Jim.
Yeah.
I'm Elizabeth Sorley, just with the Center for Communication Programs, and I don't know if the right word is pleasure, but I was out in Liberia.
Yeah.
If you look at Nelson's graph from about the day that it was the peak down to the day that it was all done. So, but Jimmy, I was thinking maybe you want to talk a little bit about you know, we really struggled a lot with so many researchers coming into the country, and the kind of some of the coordination mechanisms that we set up to help make sure that at least, even if not everything managed to go through an IRB, at least we knew what was going on. Maybe you want to talk about that a little bit?
Yeah, okay. Oh, I just see you. Yeah, okay, yeah, Liz, yeah. We met several times, several different meetings. Okay, yes, right now, as I said, there's a website called the Clean Rig. I think it's been run by the NIH. So when you go on our website, anyone wanting to do research in, like I think it's now Liberia, Guinea, and Sierra Leone. There are guidelines. You know, you want there are two. There's a three committees that you know the information is available out there. So you have the University IRB. You have the National Research Ethics Board. That's one that's run by the government. And then you have the Liberian Medicine and Health Regulatory Authority. I would say not comparable to the FDA, but you know that's the kind of role they play. And so yeah, so that's a mechanism that right now we working on in terms of streamlining what kind of a research you are conducting, what are the processes. Yeah, so the UL, RB, and the University of and the National Ethics Committee, yeah, we're working together. For example, if you want to do work in Liberia, and the National Ethics Board deems necessary that we think the university can handle this, you know, we go in there and help to facilitate that. If it is a huge, big clinical trial, usually the government wants to shoulder that. And so what happens there is that we work together, we second some of our board members to help review those protocols. So those are kind of mechanisms right now that we're putting in place.
The other thing I want to say on that, on this partnership, the essence for this partnership is that the ULRB might not have, you might have a protocol coming in that you don't have other experts on. Yeah, and so there's need to work together because you might not have other experts. Social, behavioral research, fine, you can handle that. But when it comes to critical clinical research, then we need to go to the national. They got no resources.
Question? Yeah.
Thank you, Nelson and Jimmy. Just going to build on something that came up in Nelson's talk. You had mentioned, as you're kind of going through the itinerary, a number of the measures, public health measures that were used in terms of border restrictions, checkpoints on highways. And we can add to that, I think you showed a picture maybe of West Point, where sort of West Point and Dolo Town were both locked down with barbed wire as cordon sanitaires. And also markets were closed, schools were closed for 6 months. There were a number of what I would call liberty-limiting public health measures. But sort of, when you came back to sort of the challenges and also the things that worked, So they sort of didn't show up as either challenges or as things that worked. I was kind of wondering how you thought about those, like what parts of them worked, what didn't work. Are there lessons to take away from how we regulate the use of those, given that Liberia has a very robust constitution? It's also a signatory to human rights documents. And just even thinking about public health ethics that sort of can guide how we use this. Do you feel like things were done well, they could be done better, and how would you do it again? Yes.
Okay, I will tell you that at some point in time things were done better, and some point in time it wasn't done the right way. Particularly with respect to the disease we are talking about, this is a very strange disease that entered into Liberia for the very first time. And if you are in that position as a leader, what you ever want to do is you take those kind of a decision that within 2 days you will hear that Ebola is over. Okay? So what was happening technically across the 3 countries, you saw that there were a lot of lockdowns, there were a lot of quarantining and so forth. That did not work. I tell you, it did not work. Quarantining was used particularly in way back time of our kind of a public health response. Okay, those days are different. Particularly some of the international rights agreement that have been made now wasn't existing at that time. So, for example, the quarantining of West Point, in my opinion, if I was the one making that decision, it was meant from the beginning to control people movement. But it was also wise enough for the government of Liberia to see that that wasn't the best strategy. And that's why we changed that. After West Point quarantine, there were nowhere else in Liberia that ever underwent quarantine. But if you are listening to the news as well, you have learned that it was still being done in Guinea, still being done in Sierra Leone. But we get to realize that, like I said, if you think that you are engaged, you are carrying on an intervention for a public good, it's better the public to understand that better than the way you understand it. So our approach was, we are healthcare workers, all we need to do is to get those that are sick, put them somewhere, treat them, and keep them from the rest of the people. But it wasn't right. We realized that community engagement and ownership was the best strategy for us. Onward today, that's what I can recommend for anybody to use, particularly in the control of Ebola, because this is something that has to be done by the individual themselves, not you. Okay? So things were done wrong, but over time we realized that, look, these are people that understand, talk to them, let them know the reason why they shouldn't move here and there. It's better for them to understand and live with it. And it's more sustainable in our case than when you engage ordinary approach.
Let me just add, I mean, the issue we also, like you're saying, I think what really happened was the government established an Ebola unit in West Point, but didn't get the consent of the people. They didn't know. Nobody understood. All they know, everybody is dying from this disease, and then you come to my community and put an Ebola unit in place, Ebola treatment unit. This is where, so that I was actually around. They didn't accept it, and then the government had to use some force to lock down. That was the reason why it was locked down. There was another place in Habel, same situation, but then it didn't work, and then it was lifted. So it's good to always engage the people, to let them know what is happening, and that is an ethical issue too.
I'd love to ask a question that builds on the exchange, Jemee, that you were having with Liz, if I get that right.
Yeah.
You had mentioned the issue of the very limited number of healthcare professionals, and to some degree even more limited after so many of them died, being the ones that were also called upon to be involved in research.
Yeah.
And it sounds like there were many research studies. And I'm wondering, you presented it as a challenge, but I'm wondering how you navigated that. What happened?
Okay. What happened here was this. Yeah, those are issues that were raised at the ministry level. But mind you, a what happened was that this is not an NGO, all right? The previous study is not an NGO, all right? It's a two countries partnership, U.S. Liberia clinical partnerships program. And so what happens is that the doctors, some of the doctors that are now on the trial, they had to reduce their time on trial. So for example, maybe you give 20% or 10% of your time, because you have a lot of public health institutions that need you more, than the trial needs you. So that's how it was navigated. All right. For those that decided to stay on, and your effort was needed 100%, you had to resign. You had to leave the government. But even at that, that was very, very minimal, very negligible. So some of the government nurses, clinicians that are right now working on the trial, they had to make that bargain. It means that your time on the trial will be reduced so that you have time to help in other public health facilities.
Can I add to that answer?
Yeah, okay.
The other thing that I think all three of you can attest to is people just stop sleeping. I'm not even kidding. I mean, I've never seen such a sleep-deprived but still really well-functioning group of people. People squeeze every single minute out of every single day.
Yeah. So my brain became more resilient. That's
You have to work.
I'm not sure if you all have an answer for this, but I know the U.S. military built a bunch of Ebola treatment centers. Do those seem like a resource that will be useful moving forward, or are they going to sit empty? I mean, this a clinic, so it could be used if there's staff, but I don't know if it's the military staff.
Okay, let me just respond to that. It's a very critical question that you asked, and some of the ETUs that were built was built with a design that can either be transferred or that will be decommissioned. And when I talk about decommissioning, it's not like I'm closing down the entire structure, but this structure is being either renovated or made use of in another meaningful way. So some of those ETUs that were built like in the southeast, and some were built like in Kilman, in Bombing, Bapolo. Some, yes, patients did not really enter into it because at the time of building, cases was also dropping. And so those are what we look at, the number that should have been built as decided by the US government before booming. They also met and we decided that look, this number is too much, reduce it to this number because of the current load of patients that we have. And that was important to do because if they had not done it, they would have built ETUs in the rest of the 15 counties without any patients. So what is good is that the designs that were used, those designs can be decommissioned, and that's what we are doing. Since now we are thinking particularly on the restoration of the healthcare system, those places that can be used as a mini clinic, we can still use that. Some are still being used like the community care center. So there will still be, especially for the case definition of Ebola, there will still be suspected cases because Liberia is malaria endemic, you got infectious diseases, all of those come with signs and symptoms like either malaria or fever, and they are the same signs and symptoms of Ebola. So the care centers are establishing the decommissioned areas, and then they can be there to observe as a means to control the disease. So they are still useful.
Yes, please.
Yes.
So more broadly, what's being done to strengthen the health system in the rural areas now? You mentioned an investment plan for strengthening health systems.
Yeah.
So can you say something about that?
Yeah, so what we did, we designed about 2 to 3 months ago, there was a general assessment that we did through all the 15 counties. And we linked that assessment with the implementation of the 10 years National Healthcare Policy and Plan. Because they were implemented for the 3 years from 2012, 13 up to 14. And from the analysis that we did, we were able to come up with the investment plan for a 5 years investment plan but we'll be operational for the first 2 years, and then we'll do a main line, from there we'll do the balance 2.5 years. So that investment plan considers every structure at every level in the country. So one of the key things we talked about there as maintaining the structure at the community level is enhanced surveillance system, which we try to build and make sure that every community, larger community, has this committee that is set. They have a committee that raises alarm. They have a committee that tells you what is better for that community. So things have changed a little. It's not like it was before. So we got all of those plans to do, but at the same time, we are strongly trying to mobilize more resources. And when we talk about resources, they are not only like the financial resources. All we need is that we need more doctors, more nurses, more public specialists, epidemiologists to make sure that those activities are implemented. So if we got means to build more capacity, then we are seeing it from a more sustainable point. If we don't have that, then it means that there's still a lot of gap. And so that's why we are hoping that over time we'll have more opportunity for people to get some of those very fee experience and then be ready to assist us, particularly at the very peripheral level of the system.
All right, we probably should end there, but let's thank our guests again for this really